Hi guys, this is Jody, and we're going to talk about stroke under the concept of perfusion. Just use your Pearson text as your resource when reviewing this exemplar. And these are your student learning outcomes, which are basically the same as the student learning outcomes were for CAD and heart failure. So just look these over while you're studying. And we'll jump into the overview. So when we talk about stroke, another term that is used is cerebral vascular accident. Think of it like we think of an MI to the heart. We think of a CVA or a stroke to the brain. Okay, we have sudden decreased blood flow to the localized area of the brain. And if we don't reperfuse that area or release the pressure, if it's a hemorrhagic stroke, parts of that brain tissue are going to die and the patient is going to end up with deficits. So there are two types of stroke that we're really going to focus on: ischemic, and there's some categories that fall under ischemic like embolic and thrombotic stroke, and then there's hemorrhagic, which is caused by bleeding in the brain or around the brain. So we'll talk about hemorrhages there, which could be caused by an aneurysm that ruptures or somebody who has like a trauma to the brain, either through, actually I think there was just a local football player from Geneseo who was hospitalized with a subarachnoid hemorrhage. So they would be looking at the bleeding in the brain, putting pressure on that brain that could result in stroke. So we have to be cautious of that. And this is an emergency when somebody comes in, just like you would hear an MI team called if a patient was coming in with an ST elevated MI, which means that we need to reperfuse that heart muscle so that we don't have muscle death. Same thing with the brain. If this person has ischemia going on to the brain, we need to reperfuse that brain so that it doesn't result in damage, which can result in disability or death. So pathophysiology, if you just think of the brain, I know we talked about what needs a lot of blood flow. Blood carries oxygen and nutrients, and it's the heart, the brain, the lungs, and the kidneys, right? So our core organ function. Then when you think of the heart, or think of the brain is really the control center for the body. So we can see a lot of deficits in a lot of different areas if a person has tissue death in the brain. So the brain accounts for 20% of the cardiac output and body's O2 consumption. And severe or prolonged ischemia leads to cellular death. Again, tissue death in the brain. Stroke is characterized by neurological deficits that can be gradual or rapid, and we'll talk about the symptoms. And then you may hear a term called contralateral deficit, which basically means that if you think about the way the nerves cross in the body, if a person has a right-sided stroke, they're going to have left-sided motor deficits. And the opposite is true. Left-sided stroke is going to result in right-sided motor deficits. So we'll talk first about ischemic stroke. This means there's a blockage and or stenosis of a cerebral artery, which is decreasing or stopping perfusion to the brain. So you get that brain attack, okay, or stroke. This can be caused by a blood clot that travels or has developed in the vessel, or it can be caused by stenosis, so that plaque buildup in the arteries that's caused by high-fat diets, lots of cholesterol, right? We have that atherosclerotic buildup or that plaque buildup that narrows the vessels and decreases perfusion. A TIA, I want you to think of a TIA the same way you would think of unstable angina is a warning sign for a myocardial infarction. Same thing here. TIA, or a transient ischemic attack, is a warning sign that the patient is going to have a stroke. So the deficits, they say in your book, can last minutes to less than 24 hours. I will preface this by saying if a person has a symptom of a stroke, so they have weakness on one side, they have some facial drooping or speech difficulties, like they're slurring their speech, they should be seen immediately, okay? It may be deemed that they had a TIA and not a full stroke, but then they need to look into this further to see what that person's risk factors are. So in other words, there was a celebrity, I'm trying to think who it was. It was Justin Bieber's wife. He's married to somebody famous, like a Baldwin or something. She had a TIA. So I don't know if you guys remember hearing about that, but it was in the news. she had had COVID, she had traveled, and then what they ended up finding out was she had a PFO, which is a patent foramen ovale. So it's the hole in the heart where blood is flowing back and forth between the chambers, and there's risk for clot buildup there. So she ended up having what they called a mini stroke, or a TIA, where she had a partial occlusion. She didn't kill off any part of her brain, but that would be a warning sign that she could have a stroke. So she had to have that PFO treated and managed so that she didn't later on end up throwing a clot that would cause a full stroke. Okay. So if a person, has symptoms of a TIA, you're not going to sit there and wait and see how long the symptoms last. If they have symptoms, they go in, they get treated, examined. They may be told that they had a TIA or a transient ischemic attack. So it can be caused by inflammation in the artery, sickle cell disease, atherosclerotic changes, thrombosis, or emboli. So thrombosis is just when that clot develops within the vessel, and an emboli means it's traveled from somewhere else. So we have to look at clients too who are on oral contraceptives and have other risk factors like increased age and smoking are a huge threat risk for throwing clots, as are individuals with atrial fibrillation. So clinical manifestations of a TIA include numbness or weakness of an extremity or both extremities, numbness or weakness of the corner of their mouth, aphasia, which is difficulty with speech, and visual disturbances. Again, these are deficits that are not going to be long-term, okay? So they usually last minutes, they can last up to 24 hours, but they are not prolonged symptoms, okay? I think, too, that there were a couple of women reporters or journalists who were on TV, and they were doing active reports when they started slurring their speech, and they found out that they had TIAs. Thrombotic stroke, you don't need to get really into this, so don't, look to memorize any of this stuff here, but just think about it, occlusion of a large cerebral vessel. So this often occurs when resting and the BP is lower, and you kind of have this clot buildup in this vessel. It can occur rapidly, but progresses slowly. So you might have TIA, symptoms might get worse over 1 to 2 days, but then you see maximum neurological deficit will be reached. So there's not much you have to think about here. This is just when that clot is starting to develop in the vessel in and of itself. Whereas if you have an embolic stroke, that material travels from somewhere else and gets lodged in a cerebral vessel. So I often think about patients with atrial fibrillation when I think about this. So this is the clot can develop in the atria, in the heart, and then it can get thrown from the heart. Okay, that's why it's so important for people with AFib to be on a blood thinner. Now, I will say with that is that you always have to look at the individual and the risk benefit. So if you have an older client who falls all the time, is at risk for hitting their head or bleeding out somewhere else because of trauma, then maybe just an aspirin will do. But for most individuals, they're going to need to be on a full blood thinner if they have atrial fibrillation. So the embolus is going to cause ischemia. It usually occurs when clients are awake and active. When they throw that clot, it's a sudden onset of symptoms, because if you think instead of a thrombotic one where that clot is developing over time, this is being thrown and acutely occludes a vessel. Okay, it can also weaken a vessel and lead to cerebral hemorrhage. So if you think that this happens in somebody who's diabetic, who has already weak vessels, and maybe some hypertension that increases the pressure of the blood going through those vessels, they can actually rupture that vessel, and that would be a hemorrhagic stroke, that they're bleeding into the brain. Okay, so many result from a thrombus in the heart that formed as a result of atrial fibrillation. Hemorrhagic stroke, so this is when either a cerebral blood vessel ruptures because there's an aneurysm. So maybe a person has a known aneurysm or weak vessel that they have the outpouching or ballooning. They would really want to watch their blood pressure, because increased blood pressure is going to increase the risk of that rupturing. Other causes can be trauma or tumors that put a lot of pressure on the vessels in the brain. You can have an intracerebral hemorrhage, which is bleeding within the brain, and the subarachnoid is bleeding in spaces around the brain that usually occurs suddenly. So I believe it was a subarachnoid hemorrhage that football player from Geneseo had quite recently. And if you think about the brain has the skull, right? Which is great. It holds that and protects the brain. But the problem with the skull is it's not going to expand. So if you start bleeding in your brain, you're going to start putting pressure on your brain, and you can start to see the brain shift. Okay. And that is going to really clamp down on the vessels, and that part of the brain is not going to get perfused. Risk factors: hypertension is the leading cause for stroke, so we want to make sure that if a patient has hypertension, it's being managed. Heart disease like AFib, we want to make sure that they're on blood thinners. If there are no risks for them being on it, increased risk like they are falling constantly and hitting their head or whatever. Diabetes because of the vascular changes, so we want to make sure that they're managing their diabetes. Sleep apnea increases the blood pressure and decreases oxygen in the blood, so we want to manage those sleep disorders. High cholesterol increases the risk for plaque buildup, the atherosclerosis. Smoking, especially when combined with contraceptives, is an increased risk. Sickle cell disease, because of the sickled shapes of those red blood cells, it increases the viscosity of the blood. Substance abuse, so we talked about this briefly with MI. If a person is using something like cocaine, they can vasospasm, which will cut off perfusion for a short period of time. And then ethnicity, African Americans have greater risk, and this is associated with sickle cell disease and hypertension. So you want to look at each individual patient and target their risk factors. The three-step guideline for preventing stroke is: one, you have to review the risk factors. Do they have risk factors? And then you have to reduce the risk factors. What are we doing to reduce those risk factors? Are they on antihypertensives? Are they taking their diabetic medications? Are they on oral contraceptives? Can they switch over to something that would decrease the risk? Are they willing to stop smoking? Teaching the smoking cessation. Then we want to recognize the signs and symptoms. So this is what I was saying. If somebody has a TIA, even though a TIA doesn't have the long-term effects of a stroke, we still want that person to seek treatment if they start to have these symptoms. So the real big symptoms here is face, so facial drooping. So if you ask a person to smile, you can see facial droop on one side. Arm weakness, you can have them squeeze your fingers with both arms. Are they weaker on one side? Speech, do they have slurred speech? And if they have any of those symptoms, you want to call 911 right away, because this is like a STEMI, right? We need to determine, are they truly having an ischemic stroke right now, and do we need to reperfuse that brain? Okay, so it is an emergency when we see those symptoms. So again, clinical manifestations, you can see in the image, she's been asked to smile. You can see that facial droop on one side. Weakness of the extremities is a symptom. Weakness of the face, numbness of one side, loss of vision, which would be an acute loss of vision, speech difficulties, sudden severe headache, difficulty with balance, and confusion or loss of consciousness. And I will say sudden severe headache is big for hemorrhagic stroke, as is, and I will go through another slide with the hemorrhagic stroke, but also projectile vomiting is a symptom with hemorrhagic. Complications are all over the map. So if you think that now we're having decreased perfusion and maybe death to some of the brain tissue, the brain is the control center for the body. So we can see deficits in many different areas. So I can't teach them all. You guys are going to have to tap into your foundational knowledge about the other concepts that you've learned thus far in this program. So think of sensory-perceptual deficits. If all of a sudden they have loss of feeling in their lower extremities. I can tell you I had a patient about 20 some years ago who he did not have a stroke. He had a peripheral neuropathy, and so he had no feeling in his lower extremities. And he was cold one evening, and he put his feet up on his radiator, or his legs up on his radiator to keep himself warm, and he fell asleep. Well, he basically melted off most of the skin on his lower extremities, ended up with severe 3rd-degree burns because he couldn't feel that he was burning his legs. So safety is a huge concept when you start thinking about that. Cognitive changes, almost to the point where some of these people can seem like a totally different person if they have, if they're emotionally labile, if they have impaired judgment, and that's not their norm. We can start to see those changes. Behavioral changes, communication deficits, if they have expressive or receptive aphasia. Motor deficits are big if they have the weakness on the one side or paralysis on one side, and elimination disorders. So I've cared for some patients that have a stroke that basically become trached and vented and bedbound. So it really runs the gamut. If you can have somebody have a stroke that really has minimal to no deficits, residual deficits, and then you can have people that are basically, if they don't die from the stroke, they can end up being vented. So I don't go into every single part of the brain, but I do want you to differentiate between the left side and the right side, okay? When you think of left-sided stroke, you should be thinking of language. So left language. You can have expressive or receptive aphasia, agnosia, which is the inability to recognize familiar objects. So if you gave them a penny, they might not recognize what a penny is. The alexia is difficulty reading. Agraphia is difficulty writing. And then again, because of the cross of the nerves, you have to think of that deficit on the opposite side when it comes to motor function. So if they have left-sided stroke, we think of language, and then we think of right-sided weakness. Okay, and when you think about these patients with expressive and receptive aphasia, it's very important that we figure out ways to communicate with them. We'll talk about that in a little bit. On the other side, if you have right-sided stroke, you're going to have visual and spatial awareness deficits, and its proprioception becomes an issue where they don't understand where they are in space, like where their body exists in space. They can have this neglect syndrome, loss of depth perception, poor impulse control or judgment, which is huge for safety, right? Visual changes, and left-sided paralysis or weakness. And we'll jump a little bit more into that stuff as we go on. So the sensory-perceptual changes, like I said, could be anything sensory. So hearing, equilibrium, where they're really at risk for falls, taste, smell, ability to perceive temperature and pressure, so that puts them at risk for tissue injuries. So again, issues with proprioception, which is understanding where they exist in space, hemenopia, which is loss of half of the field of visual, half of the visual field, so visual deficits, being able to see and recognize things visually is an issue. Apraxia is inability to carry out motor actions like drawing or getting dressed, and neglect syndrome. So neglect syndrome is they ignore the area that's affected. So in other words, you might have somebody who doesn't dress, if they had a right-sided stroke and they have left-sided paralysis or weakness, they may not dress that side of their body, or they might not put makeup on that side of the face. They kind of neglect the affected side. Then you can have cognitive and behavioral changes. So again, it can range from mild confusion to coma. And there's tissue damage and edema that can result in the deficits, but also increased intracranial pressure, which I do not go into in great detail in this presentation because you guys have a whole exemplar on that. In 222, you will really dive into increased intracranial pressure and treatments for that when you get there. There's emotional ability, so this means they can go from like talking to you to crying or laughing inappropriately, loss of self-control, decreased tolerance to stress, memory loss, decreased attention span, poor judgment, and that inability to think abstractly. So if you think that's back from child, when you're a young child and you can't think abstractly, everything's very concrete, they kind of go back to that. So you can really see a change in personality, and I've seen this with strokes, traumatic brain injuries, and tumors in the brain, which can put a lot of strain on the family as well when, all of a sudden you have this and these huge motor deficits, but then you have this like personality change and this cognitive dysfunction that goes along with it too at times. So communication disorders. So again, think left hemisphere, think language, because that's the language center for 88% of individuals. So you can have expressive aphasia. So they can understand what you're saying to them, but their words can't get out right. And so they can't express what they want, whereas receptive is the opposite. So they can't comprehend what you're saying to them, but they might speak fluently, but they did not really comprehend what you said. So when you have these communication disorders, what you as a nurse want to do is find a way to communicate with them. So you can use visual boards. big boards that have pictures on them, and you can use those images to help communicate what you want, and then the patient can use those as well to try and communicate to you what you want. You want to speak slowly, have a lot of patience when they have communication disorders, and they can have a mixed combination of both expressive and receptive. And then dysarthria is just the problem of the muscular controls. They might have difficulty communicating because their mouth just isn't working right. Motor deficits. So hemiplegia is paralysis, whereas hemiparesis is weakness on one side. They may have flaccidity, where they have just loss of muscle tone, or on the opposite end of that, they can have spasticity and contractures, where they almost spasm in muscles. And then they often have bowel and bladder elimination disorders. So as a nurse, you definitely want to pay attention to when was their last bowel movement. Are we giving stool softeners? How are we promoting bowel movement with this client? With diet, with their eating, activity. I don't know if they use digital stimulation anymore, because you have to be careful with that vagus nerve, but sometimes they used to do that. And then with bladder elimination, do we need to do bladder scans? Are they able to empty their bladder? Do we need to straight cath? Do we need to, I've seen some people that get to a point where they need a suprapubic catheter, but we want to be monitoring and keeping a good schedule of their elimination. So collaboration, the biggest is prevention. So identifying those risk factors, targeting that, and preventing a stroke from happening in the first place. Once you see any signs or symptoms, it doesn't matter if it's just a TIA. If you see symptoms of a stroke, you need to call 911. Time is of the essence. It is like somebody having chest pain and coming in with symptoms of an MI. We would determine in the emergency room if it's a STEMI versus a non-ST-elevated MI, right? So once a person has symptoms, they need to come right in, and they should have the stroke team down to evaluate that person, because time is of the essence. We need to reperfuse that brain as quickly as we can. And the way that they do that quickly in the hospital is through TPA. But there is a window of time. So most hospitals and facilities will say that TPA has to be given within 3 hours of the onset of symptoms. Otherwise, there's no point of putting them at risk of bleeding, because it's not going to reperfuse that area. It's been too long, and they're already going to have tissue death. After they have the stroke, rehab gets involved depending on what their deficits are. So we have speech therapy, occupational therapy, physical therapy to assist these patients. Let's see, moving on. Diagnostics, a key diagnostic test to rule in or out an ischemic stroke is a CAT scan. So again, you have these patients come into the hospital, stroke team is called. It's quick as far as evaluating this patient. They're going to want to get history. When did those symptoms start? What symptoms are they having? And then you want to get them to CAT scan to say, are they having an ischemic stroke? And if they are, and they're in that 3-hour window, we want to administer the TPA. Excuse me. So CT scan is very important. And with nursing for that, informed consent, allergies, and IV access, you want to make sure that the patient has. Pharmacological therapy, very much similar to perfusion when we talked about coronary artery disease. So aspirin, Plavix as your antiplatelets, warfarin or Eliquis or some kind of blood thinner for a person who has atrial fibrillation. Antihypertensives, because that is the leading cause of stroke, so we want to make sure that we're managing high blood pressure. And then statins, because plaque is going to build up if people have high cholesterol. So we want to give those statins. And then if they're having an acute stroke, so they have some symptoms, let's say you have a patient that all of a sudden is slurring their speech and they have facial droop on one side, you call 911, that patient is coming into the emergency room, that ambulance people have already alerted the emergency room that they have a patient in that has symptoms of stroke. A stroke team is called, everybody comes down, they do that assessment of when did the symptoms come on, what's going on with the patient. They're going to do this assessment. They're going to get them the CAT scan. If they determine it's an ischemic stroke, they're going to give TPA. Okay? They will assess with TPA any recent bleeding disorders, like did they have GI bleed or something like that. But quite honestly, they have to look at the risk benefit for the patient. You know, if we can reperfuse the brain, great, and then manage bleeding that may come as a result of the TPA, we may have to do that. But, you know, they have a team of doctors that discuss and kind of go with the plan there. Okay. So TPA, again, there is a time window. This is acute. Think of it just like you would a STEMI for heart. You're going to think of an ischemic stroke, you know, as something emergent when they're coming in that we need to reperfuse that brain as quickly as possible. And we would do that with TPA. Surgical intervention. So if we find that the person has stenosis, you know, and narrowing of those vessels, we can do a carotid endarterectomy where they go in, do an incision, and pull out the plaque to open up the vessels so that they can perfuse that area of the brain. And then they can also do a carotid angioplasty, which is similar to a coronary angioplasty, only we're doing it in the brain now to get perfusion to that area of the brain. Stroke in pregnant women is important to talk about, and I hate this because I have to teach, you know, I think I mentioned briefly about pregnancy-induced cardiomyopathy and how there have been women who have had to receive heart transplants post-pregnancy, and now I talk about stroke in pregnant women. I will preface this by saying that if a healthy woman wants to have a child, she's healthy going into pregnancy, you know, this stuff is not common, but it can happen. So you look at the individual patient, you know, did you have a patient who had risk factors going into pregnancy, hypertension, smoking, obesity, older age? You can look at, you know, paint a picture of if a pregnant woman is going to have complications, okay? It can happen because the increased hormone levels impact vessel walls and weaken those vessel walls a little bit, and then it also impacts clotting time. Okay, generally, you're going to have a pregnant woman is going to have higher blood pressure related to that increased blood volume, and then the risk for this is going to be increased in the 3rd trimester and then 6 weeks after the baby is born. So nursing care, again, I can't go back and reteach every single concept, but you have to think this is the brain that's being impacted, and the brain affects everything in the body. So mobility becomes a huge concept that you have to think of. So fall precautions, non-skid shoes, call bell within reach, adequate lighting, grab bars, all of that stuff to prevent falls. Do they have the ability to provide self-care? If not, can we get OT involved to help with equipment needs and getting them as independent as possible with their ADLs and IADLs? Communication deficits. Do we need to get speech therapy involved? Occupational therapy can help with that as well. Interpersonal relationships, as their caregiver strain. You can have an individual who was very independent, working, maybe the primary financial person in the family, that ends up with this devastating stroke. And so that's going to have a huge impact on the caregiver as well as on the patient. And it can lead to economic difficulties and social isolation. You can have people who were very independent, and now they have cognitive or mobility deficits, and they may not want to go out and be social or even be able to go out and do that. So diagnosis and planning, I did not include every concept that you have to think about, so just think outside the box when it comes to this stuff. You know, that it's not all about cognition, it's not all about perfusion. You have to tap into all of these other concepts depending on how the patient is affected by the stroke. So cognitive, are they having a cognitive deficit? You know, how can we assist with that? How can we assist with that? And then comfort, elimination is huge. You know, are they going to have to be straight cast? On a regular basis. Intracranial regulation, you're going to talk more about in 222 with that increased intracranial pressure if you have a hemorrhagic stroke. Mood and affect, safety is huge because of fall risk, and also you can have those sensory deficits. So, you know, are they going to need range of motion? Is it going to be active range of motion or passive range of motion? Getting OT and PT involved, really looking at the patient. So here I gave you guys some outcomes. You know, the client will be free, or the goals, I should say, gave you goals. Client will be free from falls during the shift. So you would anticipate that you have taught them fall prevention strategies. If they're going home, removing throw rugs, adequate lighting, clutter-free rooms, that type of thing. Let's see, the client will be able to empty bladder completely throughout the shift. So you may be doing bladder scans to check to make sure that they have emptied their bladder. If not, do we have to teach that person to self-cath? There we go. Nursing intervention. So I put this on here with the note of 5 BP greater than 180 because I wanted to remember to talk to you guys about if you have a patient that comes in and say they've had a TIA, it's found that they have carotid stenosis and they're going to go for an endarterectomy, and you're managing them in the hospital. You may see that there's an order to say keep the client's blood pressure between 150 and 160 systolically or somewhere around there. And you're going to be like, well, wait a minute, hypertension is a leading cause of stroke. Why would we want their blood pressure to be higher? Well, if you think about perfusion and the fact that we have to get blood up to the brain, you actually need a little bit more pressure to push that blood up through those vessels that have stenosis. So in order to perfuse the brain, they need a bit higher of a blood pressure until we can get them through that procedure. And then we would want a more normal blood pressure. But I wanted to put that on there to say that, because if you guys have taken care of any clients that are going for a procedure or coming for stroke, you might notice that they have an order to keep their blood pressure a little higher. Monitor for changes in level of consciousness. Assist with feeding. So does this patient have dysphagia as a result of their stroke? If so, we have to think about aspiration precautions. They would need a speech and swallow eval. Do they need pureed diet or thickened liquids? Making sure they sit up when they eat, doing that head tilt down, like chin to chest area, not completely, but to assist with swallowing, keeping suction at the bedside, that type of thing. Maintaining skin integrity. If they have paralysis and aren't able to turn or reposition themselves, making sure you're doing that at least every 2 hours and assessing their skin. Range of motion. Can they perform it independently, and teaching them on that? If not, are you doing passive range of motion with them? Fall precautions. Assistance with ADLs, and that promotion of bowel and bladder elimination. So do we need to administer stool softeners? Are we tracking their bowel movements? Are we doing bladder scans as needed and monitoring their urine output? And that is it for the slides. I will say that the slides that I gave you for printing will have a few extra slides that have a little case study, and then there's questions on the left with the answers on the right, so you can read through that. I also want you to go through ATI. I pulled together some questions out of ATI for stroke. There's 10 questions, so you guys will have that you can do. And then also there is a Pearson dynamic module on stroke with some questions with rationales, so I would definitely go through those. And if you have any questions at all, please let me know. I will say it's going to be important for you to understand the differences between ischemic and hemorrhagic strokes. And I do want you to know the differences between the left and the right hemisphere strokes and the deficits that you will see with those. And again, if you have any questions, please come and see me. Thanks.